To all the aspirants present here. Well, I am Sana Fatma, and I'm absolutely delighted to welcome you all to today's webinar we are having on MRCP PACES. And thanks for all of you for joining us today. This webinar is hosted by Farz Academy, your trusted partner in medical education, and is designed to help you excel in the MRCP PACES and exam. Well, before we begin, let me take a moment to introduce our speaker for the evening today is Dr. Varun Pushkarna, who is highly experienced physician and MRCP mentor with an exceptional track record in training candidates to achieve success in their MRCP paces. Well, also his deep understanding of the exam and practical insights are invaluable for everyone preparing for paces. Well, sir, we are honored to have you here today.
Thank you, Sana, for that warm introduction. And thank you, everyone, for joining this session. Today, we will cover some critical aspects of the MRCP PACES exam, including the new format, understanding it right, how to manage the stuff in time, and of course, trying to understand how the process works, strategies to overcome the difficult stations effectively, and some tips and tricks that I'll give you to maximize your chances of passing the PACES exam. So the new format of the PACES, if I can share some material with you, it will be really nice. So I've prepared something for you guys. Has anybody appeared in PACES exam before? So it is PACES stand for the practical assessment of clinical examination skills. So why I am telling you this? PACES stands for practical assessment of clinical examination skills. So you have to understand that they will be assessing your clinical examination skills thoroughly. And it is not like OSCE or the random exam of the USMLE where there are dummy patients. No, you will get actual patients. So be ready to examine the actual patients. That is why I always keep saying, when you look at the patients, that is the time when you should be preparing for MRCP PACES exam. Because what you will get there is the actual problems, actual patients. So they've recently actually changed the method of how to conduct the PACES exam. It was changed in the November 2023. So there are actually, what you have is mainly 5 stations. When I appeared in the exam, there was 7 stations. So now there are 5 stations, and in those 5 stations, you may enter at any point of time. So there will be like 10 candidates. So one will be sent here, 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 and another one here. So the candidates will be taken in, and it is a time-bound exam. So every 20 minutes, you will be shifted to first, and then to second, and then to third, and then to fourth. Between each shift, there is 5 minutes gap. You will be assessed by 2 independent examiners. It is very important. If you are appearing in India, you might have one examiner coming from UK or from any of the Commonwealth countries, and one, if you are lucky, would be from the country itself, India. And so when I appeared, there were few guys. I tried getting my slot everywhere, but I got it in Max Hospital, New Delhi. That's way back in 2016. So at every station, there was one examiner from UK. I was lucky enough to be interviewed by the professor and head of the gastroenterology department of King's College London. So he was the one who took my history taking session. Now, history taking session has now been removed. It has now been removed from this exam. Earlier, it used to be there. And usually in history taking, there was a patient who was a dummy patient, who was told what to do, what to say, how to reply. And in fact, the dummy patient was extremely intelligent. We could tell you that, if you are on the right track. And the examiners would just be observing you. They don't suggest anything, they don't ask questions unless the time is over. And of course, when they ask questions, be ready for the answers because the time flies, the time runs. So, my case, which I got in the clinical history, was diarrhea. So, I had to take a history of chronic diarrhea. It was a and of course, the examiner was professor and head of the gastroenterology department. I think it was Dr. Chaudhary, and at King's College London. So you will be getting now, one of the station will be communication. Now communication is changing the ground very fast. So you'll be having two communication stations. So one is communication and respiratory examination. And believe me, when they say examination, just don't go and ask the patient, how are you? You may greet the patient, but then don't ask the chief complaint. No, it is just an examination skills test. You just are told this is the examination that you are supposed to conduct. Go ahead and get the patient examined. That's it. If the patient is respiratory, you must prepare for the schema of how to assess a respiratory patient. If it is an abdominal case, you should be well prepared with how to examine a patient with abdominal complaint, and so on and so forth. So you will have a communication station along with the respiratory, and you are given only 10 minutes. So when I appeared in that exam, I was given 6 minutes. So within 6 minutes, you had to examine the whole patient, and the rest of the 4 minutes, they would ask you question. So this is then it will be a consultation. That is a long consultation. Consultation, they have now included two consultation stations, station 2 and station 5. Now this is also a big paradigm shift. Consultation, they assess you for English speaking. Consultation, they assess you for your calm, your comfort, and your convincing powers, the way you address the situation, the way you don't get aggressive, excited, angry, because they will do everything to bring you to that point. So my patient, which I had at that time a consultation, was a patient who has rheumatoid arthritis, a male patient who was started on sulfasalazine after being discharged from the hospital when he was admitted with bilateral pneumonitis of the lungs due to methotrexate. So the patient was so furious and so angry that you gave me methotrexate, and then I developed bilateral pneumonitis. I have been through the investigations, I have through the literature, and I know it was your medicine that caused it. And now you have given me some lesser medication, and my joints are hurting. So the patient needed to be calmed down, to be convinced that, okay, fine, I am not the one who gives these medicines. These medicines are a recommendation, and we treat the patient according to the general recommendations worldwide and what are accepted norms. These are the standards of care. So these are the certain words that you should use when you are consulting a patient. These are the standards of care. And in these standards of care, it would not have been appropriate if I had not started you on methotrexate. But yes, when we started the treatment, we did inform you about the potential side effects of methotrexate, like respiratory problems, like bone marrow issues, the hemoglobin can go down, the total leukocyte count can go down, thrombocytopenia can happen, and infection risk is real. So you need to know the words that you are saying. You should be practicing with somebody who knows the subject. He should be, countering you and interrogating you literally and confronting you with the situation given. So you should be very well prepared as to what you are going to say, and what you are going to ask should be in terms with the norms, the recommendations. So you should be very well aware. So there will be two consultation stations for 20 minutes each, and they are long consultations. Then cardiovascular and neurology, they are clubbed into two. My neurology case was left lateral rectus palsy. So my viva went on. She was a British examiner. She asked me as to what is the most common reason for isolated lateral rectus palsy in India. So it was basically sixth nerve palsy. And of course, my viva went from tuberculosis and focal tubercular meningitis to syphilis to multiple sclerosis and all that. And cardiovascular, I had a short statured guy who I thought was having some congenital malformation. And yes, I found out that he had aortic stenosis. And believe me, nobody tells you which patient is there. So you just have to believe on your own skills. You should have to practice them again and again. Put the stethoscope on every patient. And mind you, if you don't hear anything, like I could not hear a pulmonary stenosis murmur. She kept on asking me, what else do you hear? I told her that, ma'am, I see this patient who has a webbed neck. He's a short statured guy, could have achondroplasia. I don't know. He needs to be investigated for that. And I could auscultate a pansystolic ejection, based murmur on the right side of the sternum in the second intercostal space, and the murmur is radiating to both the carotids. She kept on asking me, what else, what else, what else? But because I couldn't hear, I did not tell. Sometimes what happens is they fail. I mean, I appeared and there were 70 odd students and only 17 passed. So that means there were people who were just trying to beat around the bush. They do not like it. If you don't find anything, tell them, I don't find anything. It could just be an entirely normal patient. It is totally up to them. And believe me, when the patients arrive, they have themselves seen all the patients before they take them up for examination. So, cardiovascular status, neurology station, and then communication again, and abdominal. My abdominal patient, if I am not wrong, was a jaundiced patient. The patient had jaundice, he had ascites, and the viva went on from, why would you want to get a complete hemogram done on this patient? Because the examiner asked me directly, uh, how will you work up this patient? So I started off in my own Indian style that, okay, I would like to get a complete blood count to begin with. And she was like, why complete blood count? So I was like, if he is having variceal bleed, he would have anemia. Then she was like, okay, tell me what are the reasons for anemia in a patient with cirrhosis, with alcoholic liver disease, with anything related to liver. And that was it. That is how the viva started. And they could steer the viva to any direction. Then she told me, fine, okay, now the hemoglobin part is done. Why would you like to assess the patient for total leukocyte count? And then why the platelet count? So they can get so deep and so notorious, because it is general for us to say we would start with complete blood count, but it is not general for them. They work in NHS. In NHS, everything is paid by the government. So if you are ordering an investigation in which you are not going to change the outcome or the prognosis or the treatment of the patient, you are not supposed to get that investigation done. So they'll be assessing you on that. So there will be abdominal station, and then communication, of course, they'll be trying to see how you communicate with the patient. Am I clear on this slide? If there is any question, you may ask right now in this carousel slide.
Varun,
Yes,
hi,
sir.
good evening. Just want to do clarification on view of student that there is a two station where communication for 10 minutes. One is your station one and your station four.
Yeah.
So what communication they will do in this?
Yeah. So in the communication, basically, they will give you something to communicate with the patient. Like they will give you a case scenario, like a patient has recently been detected with multiple sclerosis. Open up the bad news to them.
Okay.
So you should be prepared enough to, have a lot of empathy, lot of, giving space like situation. That is why it's 10 minutes. So they will just, okay, doctor, can you tell me, I was investigated for some investigations because my mom is feeling the neurologist assessed her day before yesterday. uh, what are the investigations that have come, and the diagnosis is multiple sclerosis. So one has to literally run through the tests at that time and giving them a comforting way of communicating with them as to how this thing has happened.
Okay.
Yeah.
And the next two in the station 2 and the station 5, both are consultation station.
Yeah. So consultation, yes, consultation is where I told, like, the patient who had one of my patients who had like this bilateral pneumonitis secondary to methotrexate. So this is how it will go.
Okay.
Just a second, sir. बताइए, देखिए मैं मतलब बंदा बाहर आया बच्चे आसमान. Hello. Hello. So in the communication station, they can give you any patient who has had a treatment, or maybe there is a new drug. For example, they will tell you, okay, fine, doctor, I was told that there is a new drug for MND. My father has MND, and there is a new drug. So can you tell me about it? He will just open up the consultation with you, and then uh, you would have to tell that MND is a progressive disease, and this is this. You already understand that, but then there are certain drugs that have come. So these drugs, they are still on the trial basis, but then yes, they have arrived and they have not entered into the recommendations as of now. So that means they are enrolling the patients on patient to patient basis, on individual basis, and then we just have to uh, be very very active listener there in these consultation and communication stations. We have to be very very active, and believe me, you as students, as doctors, you don't have to literally listen to reply. You have to listen to understand. So they need that facial expression from you, that you are giving them importance, stern enough that yes, go on, say something, I'm listening, that way. So the moment they stop, you can, if you don't understand it, you can explore more. You can just say, tell me, can you tell me more about it? Can you tell me more, what else concerns you? And then at the end of every communication, there is ICE questions. I is impression. So you have to ask them, what do you think our conversation today meant to you? What impression they are carrying? And then C stands for concern. Is there any other concern that I may address? Because they obviously, the consultation and the communication specifically means how you address the issue, how you comfort them, and how you say goodbye to them. Because that is important. It's not that my conversation has ended and now you can go. No, you still have to ask, are there any concerns? So what is their idea about this thing? What are their concerns? And at the end of the day, is there anything, is everything addressed? Everything is covered. So is that, was everything that you wanted to know? Then they might come up, okay, doctor, thank you for asking that, because my father actually has got himself enrolled into one of these studies, and I wish the best for him, and I would get back to you in case anything goes wrong. So just say, yeah, that's fine, welcome. So you have to be an active listener, and you need to have a lot of clarity about the topic and the words that they use. You need to structure your communication and consultation in a manner that it is logical and concise. You cannot tell them stories. You have to give them logics, like certain words are very very logical, like this is the standard of care today, this is the standard of practice, this is what is there in the recommendations. You will be asked for a consent. For example, in ankylosing spondylitis, nowadays every rheumatologist, every person who's practicing into rheumatology wants to use adalimumab. So they will ask you, doctor, is there a drug which is given every 2 weeks? So if you don't know about the drug, and it has to be given every 2 weeks, and whatever side effects it can carry, how can you go ahead and discuss the case with them? In case you don't, never shy from telling them, oh, really? I would have to go and check back with my seniors on this respect, because rheumatology is a branch which is now coming up very fast. And I have not been getting time to keep myself abreast with it. There is no shame in declaring that I don't know the drug that you are asking. This has to be very, very confidently dealt with. People just get confused, they fumble, and then they make a mess of it. This is what I don't want from you guys. If they ask you something upfront which you don't understand, tell them that I don't understand, I'm sorry, can you repeat that again for me? And then they will certainly do that, because everything is marks. The patient is not a patient, he's actually an examiner. Of course, he knows what the other student has done. And you must encourage with them like shared decision making. So when I was practicing, so I started talking to my patients on everyday basis, and I realized that shared decision making makes the patients very happy. Many times patients, they ask for, should I start the treatment? And that is the question you should ask the patient. Should I start the treatment? And in fact, if you go into the guidelines of the NICE guidelines for diabetes management, NICE guidelines for hypertension management, it is pretty clearly mentioned there, discuss with the patient. Why? Because the patient might have a problem. If they drink a lot in the on the Saturdays, you tell them, fine, you may omit the drug on Saturday, there's no harm in it. But then you have to also guide them that drinking alcohol is not good for health. So there are, in India, we follow the paternalistic approach of medicine. Like we tell the patients, you must start this medicine or else this will happen to you. No. Don't scare them. You just cannot scare them. If you scare them, they carry a very bad impression on you. So you don't do that. You should not do that, because otherwise the impression that they will carry, this is totally an impression based exercise. You should be very clear that you are not asserting yourself on them, you are making them comfortable. So the basic skills that will be assessed are actually 7 in number. It is actually given to the examiners from A to G. So A is the physical examination that you do. You have to demonstrate the correct method. So if you're auscultating the chest, you have to auscultate at 9 points. You have to auscultate on the front, on the upper, then middle, then lower, and never ever auscultate on the sternum. People do that, and that is a bad skill. Then people auscultate on the scapulae. Again, that is a wrong thing. You cannot auscultate on a bone. There is lung is behind the scapulae. So you have to auscultate just between the lungs, right? So you have to do that. Like if I have to draw a patient's back, and this is the scapulae, and so you auscultate here, 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 and then this is how you auscultate. This is just a bare minimum thing that I'm telling you. That respiratory examination, same way abdominal examination. In abdominal examination, if you did not palpate, if you did not inspect, obviously you just jump to palpation without inspecting the abdomen first, the patient will just wince with pain. You won't believe what happened with me. So there was this patient of jaundice. He actually had an IV cannula on him. When I went very close to him, what happened is his cannula got stuck with my coat, and it actually could have hurt him very much. He winced, and I asked sorry. I said sorry, I didn't see it. And then there is no harm in asking for that, because this is your clinical communication, how you are opening up with the patient. So physical examination, demonstrating correct, thorough, systematic or focused. It has to be a scheme based, that I'll do this, I'll do that, I'll do that. So neurology, same way neurology, like first you assess the patient for motor function, sensory function, reflexes, and then of course the gait disorders, and trying to have a make them walk. So you have to practice them again and again so that you don't fumble there. So it has to be fluent, it has to flow from you, and then it becomes clear. Identifying physical signs correctly, not find physical signs that are not present. This is very important. They are told to assess you on that. If you tell them anything that you could not find, and just like in India we say tukka, that you just bluffed, they will know that you have bluffed. And of course, clinical examination, getting a good clinical history relevant to patient complaints, staying focused to the point, and then fluent and professional manner, explaining them relevant clinical information, like, okay, like in diarrhea, you tell them that fine, it is very important to ask about the patient's medicine history, because your diarrhea might be related to the medicines that you are taking. So you have to tell them that why I'm asking about the medicine history. So can you tell me about any medicines that you might be taking, maybe from a doctor's prescription or over the counter or some homemade remedies? So you have to tell them that fine, you have diarrhea, so I think there might be something in your prescription that needs to be checked. Can you tell me about that? So like headache, so you tell them, uh, may I ask you, uh, because the headache can be a remnant of a past accident, or because some people have PTSD, they might have been involved in a fight where they were hit on the head by a cricket bat. They don't want to remember that, and if you ask them directly, they might get offended. That did you ever have a head injury or something like that? Ask it in a molded way. Your headache today might be having some significance from your past injuries. Can you tell me if you ever had a head injury in the past? So you explain the relevant clinical information in an accurate, clear, structured, comprehensive, fluent, and professional manner. Then giving them a differential diagnosis. Oh, it is such a beautiful thing to do, that in your mind you draw at least, if they are so clear headed, you give them more than three differential diagnoses, they know that you have failed. If you give them up to three diagnoses, they are very happy with it. Why? Because people who are juniors, rightly so, in our medical fraternity also, juniors always try to make more differential diagnosis, and then they get lost into it. These people who are assessing you on the grounds of being able to be included into the membership of Royal College of Physicians, they don't want you to screw up the case. They want you to give them three differential diagnoses, strong ones. So give them, narrow down your history and your questions to include your three major differentials. You might be wrong, but if your scheme is right and you have evolved your history taking or question asking or communications to those 3 points only, you are not, you will not be penalized for that. They want to know if you can do the things in a structural manner. Then of course, clinical judgment, like patient ask you that, doctor, I don't want to take any medication, so can you tell me something? So you have to negotiate with them and sensibly arriving at an appropriate management plan relative to their clinical situation, applying your knowledge, applying the knowledge of law also and ethics, managing their patients concerns. You seek, you detect, you ask for it, and then once you are confirmed that this is what they are wanting to seek from you, you demonstrate that you know. Even if you don't know, you show off that, yeah, okay, yeah, I still need to get back and discuss it with my senior, and I will give you my nurse's number, and you can contact her 2 days later. I will get back with the complete data, the side effect profile, and then it might be helpful for you to get back and discuss the things with me again. I will be available for another discussion 2 days later. You are not going to be there 2 days, but then this is how you end up the conversation. Same way, sometimes the patients are very angry, and when you enter the room, they tell you, "Doctor, where were you? I was sitting here for last 7 minutes, and you were not here." You tell them empathically, fine, I do understand your concerns, but there was a patient who just arrested in my unit, and I was just busy doing the CPR, and the patient thankfully has revived. I hope you understand. They are not angry, but they want to know how you address the situation. So this is important. And then maintaining patient welfare, exactly like I said, I entered the room and my coat got stuck in the patient's cannula. It was there on the right wrist and I was standing on the right hand, and so that happened. So I respectfully handled the situation sensitively and told them, I'm sorry, I shouldn't have done that, it just happened. And then the patient said, koi baat nahi, ho jata hai. So examiners are also seeing, and the patients were Indian patients, thankfully for me. So different stations are assessed on the different skills. It is the consultation where all 7 skills are checked. Otherwise, your ABDEG. ABDEG is patient welfare, differential diagnosis, clinical judgment, physical exam, and identifying. Because in patient examination, they don't want your clinical communication. They don't want you to ask any question. It is just the clinical examination that you are supposed to do. You will be assessed by 10 examiners, 2 at each stations. For each of the 8 encounters, they will complete a mark sheet. You will be given either 2 marks or borderline 1 mark or unsatisfactory 0. So theoretically, you might come out 10 on 10 or you may come out 0 on 10. So that is just like Glasgow Coma scale. Either it is like you are all there or you are not there. Sorry, in Glasgow Coma scale, the minimum you can get is 3 marks, 111. Okay, so this is called calibration. So this is how patient encounters happen. So you can actually download the sample scenarios from internet. You will get them. You must rehearse them again and again and try to see how your patients they respond to you. As far as the communication encounters are concerned, like Dr. Asif just asked, so it assesses your ability to guide and organize the interview with a subject who may be a patient himself, their relative, or some friend of them, such as a healthcare worker. There might be a nurse who has been in a situation with another doctor. She will tell, Sir, I was on my night shift and the doctor really spoke rudely to me. It spoiled my night duty and I couldn't focus and I got a needle stick injury. So, what can I do? So, this is the situation which is a communication issue. You will have to address it because you will be stationed as a SHO, station head officer. You will be there as a registrar. So you would be required to enter into such situations. So you need to be well versed with the way of working and trying to keep the knowledge of ethics, clinical knowledge, and managing the case or situation same way. And you should understand and explain the clinical information, providing emotional support also, and making sure that the dignity of the patient or the surrogate is not affected at all. So there will be written instructions for the case that are given to the candidate during 5-minute interval. You should read it very carefully. Don't rush into it. 5 minutes is a long time and it will be just one line. So 10 minutes are allowed for patient interaction. There will be no examiner candidate interaction at all. Marks will be based on the observation alone. So you and the patient, that's it. Station 2 and 5, they are consultation stations. They aim to assess the way you approach a clinical problem in an integrated manner using history taking, examination, communication with the patient or their surrogate. On some occasions, history will be told to you by the surrogate on behalf of the patient. Sometimes it's a deaf patient and they come with their own relatives and the relative explains the situation to you. Okay. Written instructions will be provided to you, usually in the form of a short note or a referral letter from another doctor. Hi, Dr. Smith. I am Dr. Smith. I'm sending you, referring this patient to you who came to me. So every information will be written in that. With atrial fibrillation, I started the patient on, let us say, acetylene, warfarin, 5 milligram per day. And unfortunately, the patient bled after 3 days. And I'm referring the patient to you for the management of INR. The patient is fine. He just cannot speak. He's already sought a neurosurgeon's opinion. And we require something different for their anticoagulation. And you have to counsel the patient for management of INR and anticoagulation. For each of consultation, 20 minutes will be given with each patient to take a detailed history, carrying out relevant examination also, and responding to their concerns. 15 minutes are allowed for history taking, examination, discussion with the patient, followed by a 5-minute question answer with the lead examiner. So they will examine you immediately. As far as clinical system examination, respiration, cardiovascular, neuro, and abdominal are usually the cases that are kept. In my case, it was general. There were 2 general cases also kept at that time. One was acromegaly, and the other one was a lady who was operated for a thyroid adenoma, and she had hell a lot of questions. So it was a 20-minute case. So there were 2 patients given. So acromegaly was already operated. He was like having a pituitary adenoma, and the girl was having a thyroid adenoma, which was operated already. Yeah, I don't remember. Maybe she had a thyroid adenoma and wanted to get it surgically operated. But then there was a lot of discussion on which are the adenomas which need to be surgically removed. How do we approach? How do we assess which tests are to be done? And how are you going to follow up the patient who has been taken up for a surgical removal of a thyroid lobule? Okay. So, for example, there is a case underneath that exam. This you can see that example of a written instructions. The candidate at cardiovascular station. This 45-year-old woman in short of breath on exercise. Please examine her cardiovascular system. So all you do is go inside, assess the patient. You might start with the pulse and then end up with the feet, or you start with the feet and end up with the pulse. So I always make it a point that patient may be cardiac, patient may be respiratory, patient may be abdominal, patient may be neuro. Always end the patient with their feet. Always. There might be pitting edema, there might be gait issues, there might be some, some marks there on the feet, maybe a diabetic foot or something. But you should always, sometimes it's the feet are very cold, sometimes there is pitting edema. So never ever leave the feet whenever you are either starting or ending. Either start with the feet or end with the feet, and or start with the hand and end at the hand. Either way, you take your call. 10 minutes are spent at each patient. 6 minutes are allowed for examination, 4 minutes for questions. So 6 minutes, you should be knowing how to speed up the examination. So examiners are very clear that candidates are reminded that inclusion of a patient with no abnormal findings is also possible. Remember, you might tell them that patient has this, patient has that, and the patient may not have anything. Believe me, patient may not have anything. Yeah. So patient may not have anything. So this is very important. This is how the paces will go. And then once you are completed, and you don't have to talk to anyone. They are observing your mannerisms. They are observing the way you connect with others. If you have to interact, maybe just a glass of water, like just to feel yourself comfortable. If you are having a glass of water, there will be water can kept somewhere, and you will just go and have a glass of water, and you may ask anyone out of respect, do you need water, can I get you one? So they are actually looking at you, how good a team member you can be. So it is a membership exam. You are to be enrolled not as a doctor, but as a member of Royal College of Physicians. So as a member, you will be assessed on how do you talk to someone who is not related, who's, I mean, obviously everybody is come there to either give exam or to facilitate the exam or to take the exam. And then there are patients who will be examined. So you have to understand that everybody has a different role there. So uh, it is very important that you just keep looking and keep seeing the patients clinically at all points of time. Any questions?
Any question from the student side?
And then I think a very in short span of time, we might be holding a proper paces training session also, where 48 real cases and interactive
Yeah.
sessions will be there. Yeah, so I think that is to be held at around 28th to maybe 2nd March.
Yes.
So Dr.
So
Asif
we
can
are
tell me.
planning to do a physical spaces in Kolkata from 28th February, 1st March and 2nd March, where we will have 48 cases, and Dr. Varun Pushkarna will be there as an examiner to help you out. So Varun, one more thing I want to ask. Suppose few of candidate they're planning to give basis exam in this March April session. So now only 2 month is their hand. So how they will prepare themselves?
Wow. So basically, one thing is very important, that you practice and practice again. In whichever setup you're working, go to the indoor unit. Like, let us say there are 10 patients. So in your ward, in your unit, see each patient with the same scheme that you have thought of every day. You have to practice it so well that it flows. I'm again telling you, you will not be assessed with the correctness of the diagnosis. No, diagnosis is something very subjective. You might have made it a wrong diagnosis. That doesn't make a difference. But how you approached, the way you palpate the lymph nodes, it doesn't happen that you start with the pulse and then you directly start palpating the lymph nodes. So try to create a scheme of how you have to assess the patient and then follow it every day, maybe 10 minutes with each patient, not by the watch but by your instinct. The more you practice, faster you'll get. My basic, the way of doing examination usually was that I would examine everything apart from neurology on the same patient. So that gives me a lot of mileage. It gives you general examination, a cardiac, a respiratory, and a gastro. So start with the pulse, then go on to the head, look at the sclera, both lower and upper, and then tell the patient to open up the mouth. Now these things are what patients is expecting from you, that my doctor has come, he will look at me and he will do ask these things. And once you have seen the oral cavity, then ask them to swallow something, look at their thyroid, and then once you're looking at the thyroid, that is the time when you should touch the thyroid, because now the examiner will see, fine, he's examining the neck. And when he's examining the neck, he's examining, first is just looking, and then when inspection, what is known as, so you look for any lumps, you tell them to swallow, and then once you've done that, then just feel for whatever finding you might have missed. Something is not visible to the naked eye, so you just feel to palpate it like you are a blind man. So if you can feel any lump, focus on that. If you don't feel any uh, bulb, fine, move forward, because there is no percussion, there is no auscultation in the neck, so you just then move to the chest. Always, if you want to examine the patient, tell them open your clothes in a decent manner, so open up the chest. Now it's your field, so inspect. Even if there is a cut, oh, there are pacemakers put in the patients. How will you know the pacemaker is there? There is a pulse generator placed here. Unless you ask them to open their shirt, and then once they open, you see a stitch mark here. And then once you see, then gently palpate it, because sometimes you palpate it so hard that the patient winces with pain. Don't do that. So just feel them. Okay, there's a device. Keep it to yourself. Don't make notes. Keep it to yourself. This is out of habit, that one day when you do this thing there, then you will be very, very clear and fluid in your movements, and that will help the patient at that time. That
And
will
well,
help you
one more
at that.
question to you. Is there any study material for the student who can study for?
Yeah, there are a lot many. There are case histories by McGraw-Hill. You can find them. I mean, if the time is not too much, then probably there is one case studies for MRCP. There is one book, case studies for MRCP, and they have like, I think they have like what, 30 cases, including migraine and diarrhea and everything. They even have color blindness in it. So why color blindness is kept in the cases? Because of the DVLA, Driving Vehicles Licensure Act. So DVLA is a responsibility of the doctors. So we have to counsel the person that, okay, fine, you have a color blindness, fine, you just cannot see the red light, you cannot see the green light. So how will you know where to stop? So it is important that you know these things also. So there is this book, I fail to remember, it's a green book, and then it's got case histories for MRCP. Otherwise, McGraw-Hill has got case histories for almost everything. You have to understand that whichever case histories you are reading, you should read it out as if it's a real case. You don't have to think that I have to cram it. You have to understand that the book, that the topic is basically as if you are going to teach it to someone. Be a teacher, because they will be looking at you as they don't understand anything. So whatever you tell them, they will consider it as a word for it. So you read any number of case histories. There's several books, but then this one is concise and it's MRCP oriented. So that is a good book.
So one more thing, that in final year MBBS for the clinical case scenario, we used to read this Macleod or Hutchison. It's going to any help on this
See,
examination?
this is the best thing what you've asked. This is a very good question. Now the thing is, they are not going to assess you for MBBS level. They are going to assess you for an MD level. So reading Hutchison as a preliminary book is very important. Like Love and there is Bailey's clinical methods also. There are a few books that I know, and then what you have to do is I was just looking for one book which I have recently purchased. I'm not able to find it. Anyhow, so what you have to do is that you have to put that examination into perspective. What is the perspective? That whatever I am listening to or auscultating, what is the differential diagnosis I'm thinking? You have to think while you are examining. You have to. So it is a good book, Hutchinson's, but then don't get lost into the examination too much. You just need a concise examining skills to establish a differential diagnosis list. That's it.
Okay. And next question is that uh, regarding this would the most of the there are few student actually ask that they want to join this PACES 3-day course, but they also want to uh, you people if do some videos for them for how to do exam, how to do.
So the thing is, we will need to have patients, actual patients, and then we will need to have a very good scheme of evaluating them, and we will later on need to have a question answer session amongst ourselves. So that is the video that can be made. So a patient, a comfortable scenario, a patient who actually has, because we will not be able to tell them that what auscultatory findings we have heard. So maybe we need a good audio visual systems where we can incorporate those things into them, as far as because from distance we can only show them the inspection part. As far as palpation, auscultation, these are all. So we will just we can give them an example, like we can exemplify them and then have a conversation between two doctors as to how we converse, how expected questions will be there, and how the replies should be done.
Okay. So any question from the student point of view? Or Varun, any conclusion mark?
Yeah. So conclusion mark is very, very important, that if you find something, shout about it. If you don't find anything, stay calm about it. It may be nothing. It may be everything. So don't lie on, don't fudge, don't bluff. If you haven't found anything, don't say it. Sometimes, examiners already know that this finding was very difficult to get out from that patient. So it is genuinely so in clinical scenarios. Do your patients every day, start your day, spend some time in uh, you should not be looking for findings. You will start finding themselves. Well, if you start looking for something, there are chances you might miss them. But then if you are just doing your regular stuff, auscultate every chest, one day you will auscultate something, and one day you will auscultate nothing. You will come to know that what is a expiratory wheeze, what is biphasic crackles, and then read about biphasic crackles. You will know that, oh, whatever is mentioned in the book is absolutely correct. In bronchiectasis, this is the pattern, because they will ask you, what does this signify? What does this signify? Looking at, you will never ever get those spider angiomas in any cirrhotic patient in India. I don't know. I haven't found it.
One
So
more thing, Varun. for in Indian exam scenario for a final exam, practical exam in MD or DNB, there the main protocol, the most of the question from the examiner started from the anatomy, physiology of this particular organ, then come to pathophysiology, then
No,
come to the management.
no.
And here, what is the difference in PACES exam?
Difference is 4 minutes. So
Okay.
you examine the patient for 6 minutes, and 4 minutes is the time there where they will directly ask you, what is your impression about the case? This is how they'll start. So, what is your impression about the case? Like I'll tell you, the case I had respiratory was actually a patient who was amputated right leg below knee, and he was lying down on the bed. He had ascites. He had a blue bloater-like face. The eyes were bulging out, and he appeared to be a smoker. So, the thing is that you cannot ask the patient. So he had ascites. His JVP was elevated, and I examined the patient. And when I started off, like, he asked me, why were you looking at the feet of the patient? Because his both right was amputated below the knee, and the left was amputated midway, mid shaft leg. So there was no pedal. I could not. I had to look for pedal edema to label the patient as having COPD with cor pulmonale. So when I was just when I examined the patient, the immediate next question when the viva started, okay, so tell me about what impression do you have of the patient? So I told them that he appears to be. See, you have to tell them that it appears to be. That is the way. That is the good way of going by the things. It appears to be a patient of a COPD, advanced stage. There might be a patch of bronchiectasis on the left lower lung, and it could very well be a mass lesion. From his lips, from the color of his lips and the breath, I can make out he might be a chronic smoker. And the JVP is elevated. He has ascites. So there are high probability chances that this patient could have cor pulmonale, and secondary to that, congestive hepatomegaly and ascites and cardiac cirrhosis. And yes, he has, his fingers were having cigarette soot on them. So I told them that fine, I honestly feel, and he had clubbing also. So you examined, and then I told him that this is all I have seen. He asked me, why were you looking for the feet of the patient again and again? Because this could have embarrassed the patient. I said I wanted to see if there is any pulmonary edema, or it could be Burgess disease. It could be a thromboangiitis obliterans, because he appears to be a smoker and he could have a peripheral vascular disease. I need to be very, very sure if I have to treat the patient that this limb got amputated not out of trauma, not out of peripheral vascular disease secondary to diabetes, peripheral vascular disease secondary to thromboangiitis, secondary to smoking, because that will help me counsel my patient to stop smoking. So they really like the preventive part of medicine a lot. So that is only 4 minutes in which they have to examine you, and of course you know your findings. So then, of course, as I told you, the gastro case, the abdominal case, the examiner started asking me, so what is your impression of the case? So I was like, it appears to be a patient of cirrhosis with portal hypertension. Then it was like shoe in the boot of the doctor, of the examiner. Why portal hypertension? So how what are the signs of portal hypertension, man? Tell me, how can you clinically say that the patient has portal hypertension? So then you have to build up your case on that. I feel that the patient might have portal hypertension because he appears very pale. He's jaundiced and he's pale also. So he might have been losing blood, and all I can think of is this patient could have a variceal bleeding again and again, and that is why he's lost blood. And variceal bleeding is a complication of portal hypertension. And then the patient has massive ascites. I can see the caput medusae, again a sign of portal hypertension. So then the question was, cannot it be a marker of intravenous IVC thrombosis? And then, so this is how they assess you. that, okay, IVC thrombosis, what is that condition known as? So, oh yeah, it's called Budd-Chiari disease. And then the next question was, what will be the difference of presentation of Budd-Chiari syndrome? Simple. You will not have kept that patient in the clinical examination exams for PACEs because it is an acute presentation, and the patient may collapse on while examination also.
Mainly they stick to the clinical questions, the
Yes,
finding
no one
based
at
and the orientation.
no one at least, unless you tell them to go into, like she asked me, what will be the workup of this patient, portal hypertension wala case. So I started with complete blood count, and she was like, okay, now I am in your den. So she said, why complete blood count, why hemoglobin, why total leukocyte count, and why can we omit that investigation because we don't want to be misled into so many of the investigations. But thankfully I said alpha fetoprotein once when she was asking me what else you will do, what else you. So then the question came on why alpha fetoprotein. Then you need to know the nice guidelines on management of patient who have cirrhosis. So you have to tell them that every 6 months you would want to get an alpha fetoprotein and an ultrasound abdomen. Why? Because you want to rule out. You don't know. You just examine the patient. It might have been alcoholic cirrhosis. It could have been hepatitis C related cirrhosis. Of course, you look for needle marks, you couldn't find any, but there are possibilities you don't find any. And HCV doesn't go through needles only, it has other mechanisms also. So, if it is a patient of hepatitis C related cirrhosis, there is a good percentage of chance that this patient may develop hepatocellular carcinoma. How will you know that? As a doctor, you will get your alpha fetoproteins done repeatedly after every 6 months. That is the guidelines. And of course, do a repeat ultrasound scan.
So,
Of course, yeah.
so student has to read the nice guideline of the
Oh, yes,
management
that is.
various
Yes.
disease.
That is why, sir, you might have noticed whenever I take classes, I make it a point to incorporate nice guidelines. Because for every topic, they have their guidelines. Like in chest, they have BTS guidelines. So they will rotate around. I mean, gold criteria. How will people know gold criteria? They don't study gold criteria for COPD. And they will be asking these criteria because they discuss only, standard of practice. That's it. And standard of practice starts with the guidelines, recommendations, and they don't want to deviate. They don't want people to experiment there. They want to people who can stick to the lines that have been drawn by their national health systems.
Okay. So thank you, Varun. It's a wonderful discussion. And
Thank you
Shana,
so much.
over to you.
Well, it was very interactive, very informative, and very interesting, I would say. Thank you, Dr. Varun sir, and thank you, Dr. Asif Iqbal sir. Well, before we wrap up, we have some exciting news for all the aspirants that we are organizing a 3-day course that is from 28th February to 2nd March. Well, after the session ends, I'll be circulating a Google form to everyone. Please fill it up and join us in our paces where Dr. Varun Pushkarna sir will also be there to help you ace the examination. Plus, we'll be having some other faculties as well.
Okay.
Thank
Thank you,
you.
Sana. Thank you,
Thank,
Dada. See you soon.
Thank you.
thank you.
Bye.